Alright, here we are going to be talking about back pain with radiating leg pain. So this is sciatica. This is some nerve-related leg pain that is related to the low back. So when we talk about this type of radiating pain, when you look at the pain patterns, you can see that we have a couple of pain patterns here. One is a more diffuse leg pain pattern. You can see that here. And you also have more of a narrow band radiating, more dermatomal type of pain pattern. And so we're going to talk a little bit more about this narrow band lancinating pain. So the patient comes in and says, I'm having pain shooting down my leg. And you have a couple of hypotheses. Now in the guidelines, both of these would be considered radiating pain because they are nerve-related pain. But we've separated them out. Spinal stenosis is one common cause, and sciatica is another common cause. We separated them out because they have different movement pain relationships. If you think about spinal stenosis, what movements tend to bring that pain on? They get worse with extension or extension rotation type movements and postures, right? Standing, walking, and they feel better with what? With flexion. Whereas with sciatica, perhaps disc herniation, some type of irritated nerve root. Remember, these types of patients, they feel worse with flexion. Their injuries are often caused by flexion and flexion rotation. And they often will feel better initially with neutral spine positioning, because if you have a really irritated nerve root, extension type movements close down the neuroforamina and create more pressure on the swollen nerve root, right? So we don't really do repeated extensions like we would for a related leg pain problem, right? A discogenic referred leg pain problem, where we use repeated movements to centralize the pain. That doesn't make sense if you have some irritated nerve root. That's why you know that these two types of back pain, disc referred leg pain, that we use centralization procedures, is different from a nerve root type of problem, okay? So let's talk about spinal stenosis briefly. You'll know that in this group, the prevalence is relatively common, right, for people coming in with low back pain. Consider that spinal stenosis is really a degenerative problem, right? We tend to see it in older patients. It's really just part of the spine arthritic changes that eventually lead to compression of the neuroforamina and compression of the nerve root, right? So you, in these types of patients, tend to see back pain and leg pain that gets worse with extension. Okay, so I'm going to move on from there. That's not a difficult thing to see. If we watch what movements reproduces pain, extension or extension rotation tends to irritate the nerve root. The nerve root already does not have enough space. Okay, so in the physical exam, what would we examine? What would we expect you to do an examination of? Well, we are the movement specialist. So in your key findings, we need to assess lumbar range of motion and observe for their pain movement pattern. Do they have limited extension? Does extension reproduce their leg pain? Do they have loss of accessory mobility, indicating some type of degenerative or mobility deficit type change in the spine, right? Because this is consistent with patients who have degenerative spine, right? Mobility deficits of the spine. So remember, in the guideline says if you think it is a nerve-related problem, we want you to check and investigate the interface. The interface here is the spine and the foramina. So here you are doing an assessment of the spine, its movements, the movements that open and close the foramina, right? Flexion and extension, and then looking at the accessory mobility. Because if you find that this joint or these tissues are not moving well, the guideline says when you have a nerve-related problem, you want to check the interfaces where the nerve runs through so that you can reduce entrapment. So you want to check the entrapment site. For stenosis, the entrapment site's in the spine, in the foramina. Okay, so we are going to move on and look, because it's a nerve root problem, we're going to do a lower quarter neurologic screen, and we are going to do a neurodynamic test, a straight leg raise. In this case, I'm not looking to disprove that it is a disc herniation. I'm using this test basically to look for pain reproduction in the lower extremity that I can change with a conformation movement, like changing the ankle plantar flexion, dorsiflexion, or if the pain is more closer to the ankle, changing movements at the hip, right? Lowering the hip and seeing if the ankle foot pain disappears. So I'm using it as a neurodynamic test. What kind of movement faults brings up this that we would want you to think about? That's right, extension and rotation, excessive extension and excessive rotation. So I would listen for the types of things they do in life and watch the way they move, right? So just for example, someone who tends to move, when you're watching them in active range of motion and you see a pattern of excessive extension, this is something that I would want to change. I would not want them to extend so early in their low back. I would want them to extend more in their hips first, then extend later as they get closer towards neutral. Okay, these are just examples. You can look through these, and I'll do another quick talk about how to analyze movement in the lumbar spine. All right, so we're moving on here. One thing to consider, this we believe is related to degenerative changes in the spine. So if you look under associated impairments, the guidelines would say, please check the joints above and below the lumbar spine. Here we are, hip assessment, thoracic assessment, right? Looking for mobility deficits in the hip and thoracic spine that we can restore. All right, and now we are going to go into interventions. The guideline says when you have some type of neurogenic pain, right, some type of nerve-related pain, please go and reduce the entrapment. So if you're having excessive tone in the erector spinae, that's creating compression in the foramina, right? Because if these muscles are always on, always compressing the spine, can't that affect the nerve root? Then please reduce the spine, erector spinae tone, right? If you find stiffness in the low back, please improve the mobility of the low back. So you're basically reducing entrapment by doing so. And there's evidence to show that spinal stenosis does benefit from this type of manual therapy. If you think that the patient needs some space in the foramina, go for it. Do some lumbar traction, right? Do some rotation, right? Open up the foramina to give the nerve some space, right? You're basically reducing entrapment. And ultimately, because this is a nerve problem, we need to improve the nerve sensitivity and mobility. You might start with some very light traction with straight leg raise, right? Applying a traction force while you're doing the straight leg raise. Or typically we will start with straight leg raise slider type movements, right? Because there's very little strain on the irritable tissue. And eventually, as the patients improve, you can move into straight leg raise tensioners, right? Give them a little bit more end range. And finally, slump sliders. Hey, this works quite well also because we've opened the foramina, right? The lumbar spine is flexed, which is their relief position, their ease position, and I'm adding some nerve mobility. Therapeutic exercise-wise, you will see that I'm going to do stuff that reduces the entrapment, double knee to chest, right? Flex the spine open, quadruped rock back, flex that spine open, give the nerve root space, and give them exercises to improve their nerve mobility and their nerve sensitivity. And very importantly, under motor coordination, I need to, if they are people who excessively extend, or if they are people who excessively rotate, I need to reduce that because we believe that that might be causing daily, right, compression on the nerve roots. So, last of all, there's patient education. You guys can check that out when you have time. And that is the gist of this pattern, the extension sensitive radiating pain. I'll do another quick run in this next set related to flexion sensitive radiating pain, more like disc herniations and sciatica. All right, so this is Dr. Wong signing off. We'll chat with you guys again. Next one we'll be talking about is flexion sensitive back pain with radiating leg pain. Right? Talk to you guys soon.